Adrenal insufficiency. It is the inability of adrenal glands to generate enough glucocorticoids and mineralocorticoids for the body's needs. The glucocorticoids include cortisol, cortisone, and prednisone. The mineralocorticoid includes aldosterone. Types of adrenal insufficiency are primary, secondary, tertiary. General symptoms include weakness and fatigue due to cortisol deficiency, as cortisol helps regulate energy production. Orthostatic hypertension. This is a form of low blood pressure that happens when standing up from sitting or lying down. Aldosterone helps regulate blood pressure by managing sodium and water balance. Deficiency in aldosterone cause hypertension. Muscle aches. Low cortisol can lead to electrolyte imbalances such as low levels of sodium and high levels of potassium. These imbalances can cause muscle cramps and pain. Weight loss due to cortisol deficiency, as cortisol plays a role in metabolism, including the regulation of appetite and the conversion of nutrients into usable energy. GI disturbances, as cortisol influences the functioning of the gastrointestinal (GI) tract. Sugar cravings due to cortisol deficiency, as cortisol helps maintain blood glucose levels by stimulating gluconeogenesis in the liver. Salt cravings, as aldosterone regulates sodium balance in the body. When aldosterone levels are low, sodium is lost through the urine, leading to salt cravings. Primary adrenal insufficiency. Deficiency of aldosterone and cortisol production due to loss of gland function. Symptoms include hypertension, hyponatremic volume contraction, as lack of aldosterone decreases tubular sodium reabsorption and consequently allows sodium ions, chloride ions, and water to be lost into urine in great profusion. The net result is a greatly decreased extracellular fluid volume and hyponatremia, hypochloremia, hyperuricemia, as dehydration occurs due to the lack of aldosterone. Dehydration reduces renal blood flow and glomerular filtration rate, GFR, impairing the kidney's ability to excrete uric acid. Hyperkalemia and metabolic acidosis develop because of failure of potassium and hydrogen ions to be secreted in exchange for sodium reabsorption. Skin and mucosal hyperpigmentation due to melanocyte secreting hormone, a byproduct of adrenocorticotrophic production from propionate melanocortin. Primary adrenal insufficiency may be acute or chronic. Acute. It has a sudden onset, may be due to massive hemorrhage. A severe hemorrhage can lead to direct bleeding into the adrenal glands. This can damage the adrenal cortex, impairing its ability to produce essential hormones. Patient may present with shock in acute adrenal crisis due to the sudden and severe deficiency of cortisol and aldosterone, leading to cardiovascular collapse and inability to maintain blood pressure. Waterhouse-Friderichsen syndrome. Acute 1-degree adrenal insufficiency due to adrenal hemorrhage associated with septicemia, usually Neisseria meningitidis, disseminated intravascular coagulation, as the sepsis triggers widespread activation of coagulation and also contributes to the development of endotoxic shock due to the release of bacterial endotoxins. Chronic, also known as Addison disease, due to adrenal atrophy. Destruction by disease, e.g. autoimmune TB metastasis. Congenital failure to secrete cortisol. Adrenalectomy. Failure to take hormone therapy. Adrenal crisis is a common symptom of primary adrenal insufficiency characterized by sudden collapse associated with an increase in need for large quantities of glucocorticoids. The condition becomes fatal if not treated in time. Causes are exposure to even mild stress, hypoglycemia due to fasting, trauma, surgical operation, as all these require increased cortisol levels. Sudden withdrawal of glucocorticoid treatment, as abrupt cessation of exogenous glucocorticoid therapy suppresses the adrenal gland, causing temporary adrenal insufficiency until normal function resumes, potentially leading to a crisis if not properly managed. Points to ponder. Primary pigments, the skin, mucosa. Autoimmunity is most common cause of 1-degree chronic adrenal insufficiency in Western world, associated with autoimmune polyglandular syndromes. Anion gap remains normal in primary Addison disease as it does not directly impair the kidney's ability to regulate acid-base balance, and the body may use the compensation mechanisms such as respiratory compensation, hyperventilation, and renal adaptation, increased reabsorption of bicarbonate. Sensitivity to olfactory and taste stimuli increases in adrenal insufficiency as glucocorticoids are essential for normal function of nervous system. Vascular collapse occurs in adrenal insufficiency because the blood vessels fail to respond to adrenaline and noradrenaline. Adrenal insufficiency causes water intoxication after intake of large quantities of water as glucocorticoids play a role in maintaining water balance. Pure salt depletion, secondary dehydration, occurs when fluids of high sodium or chloride content are lost from the body and are replaced by salt-deficient fluids. Basal metabolic rate is decreased due to the lack of cortisol and aldosterone, leading to impaired metabolic processes and reduced energy expenditure. Secondary and tertiary adrenal insufficiency. Secondary is seen with decreased pituitary adrenocorticotrophic hormone production. No skin or mucosal hyperpigmentation due to ACTH deficiency. No hyperkalemia as aldosterone synthesis is preserved. Tertiary is seen in patients with chronic exogenous steroid use. Chronic steroid use suppresses the hypothalamic pituitary adrenal (HPA) axis, leading to reduced adrenocorticotropic hormone (ACTH) from the pituitary gland, precipitated by abrupt withdrawal due to the prolonged suppression of endogenous ACTH. Aldosterone synthesis is unaffected because aldosterone production is primarily regulated by the renin-angiotensin-aldosterone system. Diagnosis. Diagnosis involves measurement of serum electrolytes, morning or random serum cortisol and ACT. Response to ACTH stimulation test in individuals with normal adrenal function. The adrenal glands respond to the ACTH by significantly increasing the release of cortisol, and if the adrenal glands are damaged, they won't produce sufficient cortisol even when stimulated. Alternatively, can use meteropone stimulation test. Meteropone blocks last step of cortisol synthesis, 11-deoxycortisol converted to cortisol. Normal response is decreased cortisol and compensatory increased ACT. In adrenal insufficiency, ACT remains decreased after test. Scenario. A 45-year-old woman presents with a 6-month history of worsening fatigue, muscle weakness, weight loss, dizziness upon standing, and frequent episodes of nausea and abdominal pain. She also reports increased skin pigmentation on her elbows, knees, and palm creases. Her medical history includes autoimmune thyroid disease. On examination, she is hypotensive, 90/60 mm of mercury, and shows notable hyperpigmentation. Laboratory results reveal hyponatremia, hyperkalemia, hypoglycemia, low cortisol, and elevated ACTH levels. The diagnosis is Addison disease, and the key points have been highlighted. Treatment includes administration of glucocorticoids and mineralocorticoids. Your fear of looking stupid is taking you behind. Subscribe, like, share, and comment.